I'm Mary Beth Kudrick. I'm with the class of 2015, and I'm from Detroit, Michigan. So I welcome everybody back from our Go Lions, God help us. Welcome everybody back from the great afternoon we had yesterday. And so Yaz Winkler is here with me to introduce our next session. We're going to spend the next 90 minutes, and we're going to be talking about lessons from the payer initiatives, payer side. So I represent a kind of an employer-like payer, a trust, paying retiree health care, and Yaz is with United Healthcare. So we're here to talk about an initiative around oncology management, which is a really great initiative in that it's both looking at quality of the oncology protocols as well as linking that to, as well as cost and cost management of the episode of treatment of oncology cancer treatments. You know, in our organization, I thought about Gil's presentation yesterday when he flashed that word cancer up on the screen. We have the same type of thing that affects how we look at those cases, and do we really try to do that much to intervene and manage those protocols? But we are looking at oncology management right now as a potential strategy going forward. It's a it's our highest cost episodes in our trust. So with that, you're at your tables, and what we're going to do is we're going to have a series of presentation content. Yaz will introduce our speaker. And then with that, you'll have a couple breakout sessions where we will have a couple questions for you to think about, brainstorm on, and then we'll have a series of opportunity to interact, and then Q&A at the end. So with that, I'll turn it over to Yaz to introduce our speaker.
Is it working? All right. Okay. All right. So it's my, good morning, everyone. I'm class of 13, by the way. You probably can tell just because of the way I am. We try to break the MHCDS team before we even got to the next class. Anyway, it's my privilege and honor to introduce my colleague, Dr. Lee Newcomer. And Lee is head of oncology, genetics, and women's health over at United Healthcare. He is kind of our foremost authority when it comes to cancer care, for sure. We look to Lee for many, many things. So let me give you a little bit of background. You have his bio in your packet, and if you haven't found it yet, along with the agenda, it is in there in that two-pocket folder. So he began his management career as medical director for Cigna. Okay, we'll forget about that he ever worked for them. But from 91 to 2000, he was the chief medical officer at UHC, and where he basically worked on the development of performance measures and incentives to improve clinical care. He left us to found Vivius. Did I say that the right way? Okay, I said it the right way. Consumer-directed venture that allowed consumers to create their own personalized health plans. And Lee and I have sat together on our PDL committee, so sometimes we both ask the same kind of questions, which is really interesting about the impact of how we're dealing with pharmaceuticals in terms of formulary and also from a prior auth perspective, so very consumer oriented in terms of his thinking. And then he returned to UHC in 2006 to focus on combining clinical, financial, and administrative incentives for improved and affordable care, cancer care. He's a certified medical oncologist. He practiced medical oncology for 9 years in Tulsa, Oklahoma, for the Oklahoma people in the crowd, and Minneapolis Park Nicollet Clinic. He's the former chairman of Park Nicollet Health Services, an integrated system of physicians and hospitals in the Minneapolis and St. Paul metropolitan area for the Minneapolis people in the crowd. He earned a BA degree from Nebraska Wesleyan University, an MD degree from the University of Nebraska College of Medicine, and a Master's of Health Administration from the University of Wisconsin at Madison. He did his medical oncology in fellowship in the Yale University School of Medicine. So, without further ado, let me turn it over to Lee, because we've got a lot of stuff to cover.
We do. Thanks, Yaz. All right. You did hear my background, a little practice, chief medical officer in an organization that was about $4 billion by the time I left. It's now $120 billion. So, it was not the same organization that Gail managed at all. And I would describe myself as much happier as an innovator than as an entrepreneur, because entrepreneurs, there's no safety net. And I love being in an environment where you can be creative but still have a safety net. And that's what we're going to talk to you about today here, if we could. So let me start with a slide that I hope maybe you've seen. Does this slide look familiar? You haven't seen this in one of your courses yet? Well, this slide tracks two things. The first thing that it tracks is average U.S. household income. And these are actuals. You'll see right here, this is where we start going into projections based on the trend lines from the actuals. Okay? Now, it turns out that's wrong because during the Obama administration, this has actually declined and is just now beginning to rise again. And the second thing it tracks right here is the amount of money that it takes to buy a health care insurance premium for a family and to pay your out-of-pocket expenses. All right? So those two little arrows, this is 2016? I know I like this number because my son started college, my youngest son, and this is my liberation date. But look what happens here, and it actually happened in 2014. We are way ahead of projections. At this point in time, it took 50% of the average U.S. household income to buy your health care premium and pay out-of-pocket expenses. 50%. Yeah, you should be saying, wow, that is a big number. And you know, if you go out on the street and say to Joe Blow, do you really spend half of your income on health care? Of course they're going to say, what are you talking about? It's all paid by someone else today, so they don't see it. But they don't recognize that they see it in lower wage increases, lost jobs, a lot of other things that are going on. And that's a big number. And if you look at the projections, this is actually when my last son will graduate based on his current academic standing. Out here somewhere, it'll actually be closer to 2025 now, because unfortunately this is going down and that is still accelerating. It will take the entire U.S. household income to buy health care. Does anyone believe that will happen? Yeah, I don't either. So what's going to happen is we have to have some rather dramatic and some really big change, and it's got to happen right now. There is no, oh, we can put this off another decade, which is what we've been doing since about the 60s and 70s. We've always found a way to put a little more money into the system. We have a lot of people trained to think about revenue and very few people trained to think about cost. And that's what we're going to talk about today. So I happen to look at that every morning when I get up and get a little panicky, and my assignment at United is to think about cancer issues. And let me just give you a little background. Around 2007, when I returned to United, cancer was inflating at 15 to 17% annually. It's about 11% of our total budget, but at some places like the UAW, it is now your biggest expense item. And that's going to be the case for most people that have older populations. So most of cancer medicine involves, you know, all the focus is on drugs, especially now as these prices have been increasing. And the way the system is set up is that almost 90% of care is given in an oncologist's office by infused medications. And when I was practicing, there were still dinosaurs roaming the earth out at that time. When I was practicing, if we had an expensive regimen, it might have been $350. Today, our average daily regimen costs about $11,000. And the way that the business model was set up is that an oncologist would buy those drugs at wholesale price, they would infuse them, and they would charge the insurance company retail price. And retail went under the mysterious name of average wholesale price. It was a totally fictitious number made up by pharma. And the nice thing was there was a huge spread between AWP and what we actually paid for the drugs, and that fueled the entire practice, except that it got out of control. And so about somewhere in the neighborhood of 7 or 8 years ago, the Fed stepped in and started to control what they paid for pricing of drugs, and that changed things dramatically. But today, an oncologist, about 80% of the revenue in their practice comes from drugs, and 70% of their profits comes from drugs. So the more they give and the more expensive a medication they use, the more they make. And that is the incentive that they're responding to today. That's how we set up the system, so it shouldn't be a surprise that that's how they work the system. So as you look at the total cancer care issue, though, drugs are actually a surprisingly small amount, somewhere around 24%. This is 2 years old. It's now creeping up in the 28, 29% range. But the vast majority of cancer care goes to a hospital, also inflating at either double digits or very high single digit rates. Okay? So their inflation rate has nearly kept up with pharma. And physicians make up about 22% of the rest of the expenses we have, and they are deflating at about -2% per year. Okay? So the money is going to the big industries. The smaller cottage industries are losing out. And a lot of it has to do with negotiating power. So we're going to skip this first one. And let me just tell you about what it is that we were doing prior to the onset of this innovation. We'd set up a line of service. This was a brainstorm idea, or a brainchild idea of a guy by the name of Mike Mikan, who had come in right before Gail did. He wanted to devote a team of people that would just focus on cancer and cancer only. So our team is very small. It was 8 people at the time, and we have a couple of clinicians, 3 very good data analysts, one of whom is at the PhD level, some project managers, and our job, we had this little pink hall pass. We could go anywhere in the company, and we could go attack a cancer problem, either better quality, better cost. So whether it was customer service, contracting, medical management, we got a pass. One of the first things we did was change the standard by which we decided to cover drugs. In a typical environment, a medical director would get a request, they'd try and go to the literature, they'd make their own decision based on their impression of the literature. And so not surprisingly, we had very inconsistent decisions, and no matter what decision we made, no matter how well conceived, people said, you're just trying to save a buck. You can't possibly do this in an unbiased way. So we went to an external source. The NCCN is the National Comprehensive Cancer Network. It's 20 academic centers. They've written guidelines, and they created a document that says, here are the drugs that work, and here are the ones that don't. And we said, if they approved it, we will as well. Contracts went out. That spread that used to be there, we narrowed down. Now, in the commercial world, profit margins on those drugs now are about 22% for us. The government squeezed it down to 6%, and now 4%. And as a result of that, the margins got squeezed so tightly from Medicare that a lot of physicians had to give up practice. They could not make expenses on a 6% margin, and so they sold over to a hospital who has far more negotiating clout. And now I'm paying at that hospital, on average, 148% over cost. So not the best of strategies. We also looked at some targeted drug reviews. Interestingly, these 2 drugs alone, when we just said, let's look at the NCCN criteria and really apply them carefully, look at timing, sequences, and so on, this drug dropped its usage by 85%. It used to be our leading drug. You can't even find it now on the scales. And Avastin usage has dropped by 50%, and all we did was say, just pay attention to the guidelines. So there were some things we could do. Our inflation rate was in the low single digits. Our competitors were still running in double digits. That was a good thing, but it wasn't enough. And so we needed to think a little further. So about 2009, I was at a physician conference. A good doc from Atlanta pulled me aside and said, can you talk? And 3 bourbons later, we both realized that we were in trouble, both from the bourbon and the situation we were in. He was saying to me, look, the more I do, the more I get efficient, the more I try and help you out, the reward is I don't make any money. My revenue goes down, my margins go down, so I don't like that. This was a very conscientious guy, Dr. Bruce Gould. His business partner was with us as well, Scott Parker. And they're both saying to me, we'll try something new with you. Let's find out a way to do something entirely different. So we took out literally a napkin. This is a true napkin story. And started sketching out what is it we'd like to have if we could just start all over again. And here it is. We wanted a system that said, we'll reward the doc if he does good work, not if he does lots of work, okay? So we want to change this to an outcome basis. So if she's either getting better results, meaning improved survival, or is reducing the total cost of care, we want to pay her more. Okay? We wanted to create a system where we completely separated that dependency on drugs. We wanted to completely divorce income from that. And then finally, we wanted a learning system. We wanted a way to say to docs, all right, here's some data to help you understand how to get to objective number one, better results. And nobody had done that, including us. So the next step, let me just give you some basic definitions. We created what we called episodes of care. And we're going to focus on breast, colon, and lung cancer because those three entities make up 65% of everything that comes in an oncologist's office. An episode is a clinical situation where I can get everybody in this room to agree on the basic strategy, but I can't get anybody to agree on tactics. So what do I mean by that? Stage 2 breast cancer, it's early breast cancer, has a lymph gland or two, and if I got a set of oncologists in the room, 100% of them would say those patients need adjuvant chemotherapy, 6 months of treatment right after surgery because it clearly improves cure rates. And then if I said, great, what chemotherapy regimen would you use? There'd be fistfights, yelling, screaming, because there are at least 15 of them that have good evidence to support them, and everybody has a favorite. Okay? That's an episode. That's perfect for us. That's what we wanted here. Average sales price is a term of art that comes from the federal government because of the cost issues that were going on with pharma. About 6 years ago, CMS said to pharma, you have to, every quarter, report to us how much you sold your drugs for. And we will then take that data and we will create the average sales price, and that will be the basis for our reimbursement. We'll add 4% onto that for the medical oncologist, and that's what we will pay him. Now, it is the average, so bigger groups get bigger discounts. It's not a perfect number. Small groups will be paying a little more than ASP, but as a general rule, that represents the price that oncologists would be paying to acquire the drug. Okay? You with me on that? A chemotherapy cycle is just the recipe. What are the drugs? How often do I give it? And then the regimen is the number of times I do that recipe. That's the way we look at it. And this can be infinite in some cases. If you're treating somebody who has relapsed cancer, you treat them as long as they respond. So hopefully you use it a lot. But if you're treating early after surgery, called adjuvant therapy, for cure, there's generally a prescribed number, 4 treatments, 6 treatments, 12 treatments, and so on. So here's what we dreamed up. We created 19 different episodes for breast, colon, and lung cancer when we used that strategy and tactics technique. So we gave those episodes to the medical groups and said, all right, in that episode, what do you think is the best treatment regimen? And we let them decide. We didn't tell them which pathway they had to take on. We said to them, you look at the literature, you have your meetings, come back to us and tell us which one you think is the best treatment. And that took some time. There were lots of shouting matches, according to the chief medical officers in the room, because people had some strong emotions about this. No data, just emotion. So it was a classic doctor discussion. All right? My father once said that any physician he knew could get in an argument with someone if they were in a closet, alone. Once we had that, then we basically said, okay, we've got a contract with you already. Let's go in and look at that contract, figure out what we would have paid you above and beyond ASP for that regimen. Okay? So how much drug profit did you make on the regimen you just selected? And that money we put in one bucket and called it an episode fee. And we paid the group that bucket of money the first day they saw the patient. So it gave them cash flow, gave them some guaranteed margin that they knew was going to be there. But there was a string attached, and that is we drew this line in the sand and said, all right, that's your payment for taking care of the patient going forward now. Now life's going to change. New drugs are going to come out. New regimens are going to be proven. And you can change your drug pattern anytime you want to. If there's new evidence and you think you should be changing, that's just fine. We will always pay you the cost of the drug, the ASP. You'll never be at risk for that. But the episode fee isn't going to change. That's going to stay fixed until you can prove to us with some data that you've either improved the care or reduced the total cost of care. So there's no more inflation going on. There's no more add new, more expensive drugs, I make more money. It's a fixed patient care fee based on what you used to make, so they didn't have to take a haircut. But going forward, the only way they get better is, the only way they get paid more is to get better. Does that make sense? Everybody with me? Okay. You guys are smarter. It took usually 9 or 10 explanations of this to an oncologist to get them to figure it out. And then here's the other caveat. You had to meet with us once a year and go over performance data. We tried to make this as simple as possible for the doc. When the patient got enrolled in the episode fee, we got 1 page of clinical data that tells us they were in the right episode. But we used that data combined with claims data to help the physicians understand what was happening and how they compared to the other practices across the U.S. that were in this program. Okay? And then eventually, we hope to see if we did anything with outcomes. So what did we worry about? Well, it turns out that a couple of the biggest problems we ran into is the office couldn't find our patients. Okay? Most offices are geared to see the patient for the clinical problem, and the physician generally never knows who the payer is. And most offices have somewhere in the neighborhood of 70 different payers. So it turns out that for us to get notified about these patients to make the payment was an incredibly difficult burden. And if they were treating the patient for a month or two and then discovered, oh my gosh, this is a United patient, we had to go back and readjust all the claims on our side and their side as well. Huge amount of work and not very much fun. And here's the other problem. Somebody mentioned this, patient access. They now realize that if they were going to reduce the total cost of care, they got to keep people out of the hospital. They got to be more careful about drug toxicities. And they were finding that patients couldn't get a hold of them. Every clinic extended their hours. They now started having early evening hours, they had Saturday clinics, and they took their own ER after-hour calls rather than just referring to the ER. Every one of the 5 clinics we worked with did that because they saw the potential problem. We have a very hard-coded system that isn't terribly flexible. So we had to go hire some monks to pay these things by hand with hand scribing, to pay the claims. Now I'm exaggerating just a bit, but not much, okay? We had to pull the claims out of the system, send them over to a unit that literally manually adjudicated these claims. And that's not a very scalable solution right now. And second for us was this was a garage project. The way we are compensated at United is the savings that we bring forward on a fiscal year basis. Okay? This is a 3-year project. So I had targets to hit with my group for every year. These weren't going to show up, and we had to do our real work first and then get to this project. So a lot of this was kind of mission-driven for us, and that people did a fair amount of this work on their own, or they scaled back a little bit on the stuff they should have been working on and put their time in here.
Why do you care about preserving independent oncology practices?
Because remember what I said when the physician office was acquired by a hospital, what happened to my pricing? It went from a 22% margin to a 146% margin. So I get to pay twice as much for exactly the same service, a little more than twice as much.
And the same outcomes?
What outcomes? The hospital can't show it to me either. So that's an interesting question, but I'd love to have that discussion someday. But today, everybody says, trust me, I'm quality, and I don't trust them. I don't know that that's the case yet. Okay. All right, so now I want to take you on just a little bit of a different journey. We said you had to meet with us annually for measurement. So we would sit in a room like this, and I'm going to show you a few of the slides that we did. But we had a couple of ground rules. Ground rule number 1 was all this data was identified. You were going to see how you compared to your peers who were sitting at the same table with you. And the ground rule was if somebody was way out of whack, that's an opportunity, not a failure. So we saw variation as the ability to be basically collaborative. The 5 groups that we chose were in the same pot. In order to get enough statistical validation, we had to combine 5 groups. So if one group was way out of whack, all 5 groups had an interest of getting them back in the line because they were all going to be rewarded on the total group performance. That was not intentional on our part, but turned out to be kind of smart purely by serendipity. We had 64 discrete measures, all generated through claims data. So we produced the measures. The groups did not have to do any of that work. They had to give us that clinical data on the very first day the patient was enrolled. Again, that was a deliberate strategy. We knew they did not have time to do measurement, so we wanted to help them out as we could. Now, our problem is that we're always behind the game. We're using claims data, comes in a couple of months after the event, takes about 3 months to get scrubbed and put into our databases, so we're always a half year behind. And we're looking back in the rearview mirror, but at least it may show us some opportunities. And claims data, most of the time, generates a good hypothesis, but we may not know the real reason for what we're seeing. That takes some extra work. So I want you to imagine that you are now the oncology groups, and we're going to show you some data. And again, you're going to get to work on some of that data. So here's a very typical slide that we did for every episode condition. Okay? This is at early stage breast cancer. And one of the outcomes here was what's the total cost of care, and that's what this shows basically. So we have a database that we were comparing to that contained at this time about 60,000 patients who had breast, colon, lung cancer where we had enough clinical information that we could put them in an episode category. Okay? Now you can't do that with straight claims data alone, so the folks at Aetna and Cigna and Blue Cross don't have that capability. We had been out gathering that information for a while and getting prepared for this. We'll sell it to Aetna, Cigna, Blue Cross, if anybody's from one of those organizations. We're happy to license that to you. So that's the national standard. The blue bars represent the ASP cost of drugs. Okay? This is what the physician paid. Red bars, hospital costs. Green bar, only in the national, is the drug margin. So this is what United actually paid. Green bar plus the blue bar. And then this is everything else. Hospital, diagnostic x-rays, laboratory tests, radiation therapy, you name it. Okay? And here's how our groups stacked up. So in this condition, the groups had 14, 33, these are the number of episodes. This TC, it turns out by coincidence that all 5 groups selected the same chemotherapy regimen. These are 2 drugs, Cytoxan, Taxol. They're given for about 6 months' time. And all of the groups said, yeah, that's the best regimen for this group. Anybody see a problem? So if they're all using the same chemotherapy regimen, one of them was able to treat patients on average for, what here? $11,000, $12,000. Yet the other group took $22,000 to do the same regimen. Are their patients twice as large? They are weight-based, but it doesn't seem like people are skinnier in, where was that? Skinnier in Kansas City than they are in Fort Worth, Texas. What's going on? So everybody on this side is going to get to solve that problem in just a minute, okay? So that we looked at that data and we were equally as puzzled, and I'll show you how we got through that in a minute. Now here's the second set of data. One of the things we showed them on every episode was how they did in ER and hospitalization visits. ER here, obviously, rate per 100, inpatient days per 100 episodes, fairly tight clustering of all the groups, including our national average here. But the Kansas City group struggled a little bit, at least on all metastatic disease. So we looked a little further. Here's adjuvant breast cancer. Here's our friends at Kansas City again. And now we're looking at colon cancer, and our friends in Kansas City seem to be very consistent in their practice, and they're way out of line. What's going on there? We decided to look at what really happened to those patients. So here's Fort Worth, Texas. 15 patients. 6 of them got TC. The other 7 got a whole bunch of other stuff, not TC. The group committed to TC being their regimen. That's what they said was the best regimen they should give. but they seem to be a little short on internal controls among their partners, right? I'm sure that surprises any of you who have ever managed physicians, okay? Dayton, similar story. 7 patients got TC out of 14, and then somebody went off the reservation again, okay? Kansas City, smaller number of patients, but only half of them got TC. Northwest Georgia are stellar players. These guys are the best we have. 17 out of 33 got TC. No internal controls. And all we had to do was break the data down and found out that people got a lot of stuff. Now, this generated some really great conversation. So the next question from us was, okay, why can't you keep control of your docs? Right? And it was a pretty good straight line. So the fact of the matter was, though, is that they didn't have the consensus they thought they had. I won't get into all the technical details here, but there are some docs who believe that within this episode, there are some patients at higher risk than others, and they should be getting more aggressive chemotherapy. But that didn't come out in the discussion they first had. So when we went back, showed them this data, they said, oh my gosh, we got a problem here. And so in the future, we have now split this into 2 different episodes, one with high oncotype scores, higher risk, and those with lower oncotype scores, lower risk. And the low-risk people still get TC, much better compliance, but the high-risk people are getting medicines that have adriamycin in them. You'll notice that as you look at this, there's a lot of, this A is adriamycin, that's, or doxorubicin in this case. It's just a brand name versus a generic. All of a sudden, that's showing up in a lot of these categories. So our episode was probably not perfectly conceived, but it took the data and the discussion to figure that out, which was really useful. Kansas City was shocked by this information. We gave them the list of all their patients who had been hospitalized. Within 4 days, they had pulled every single record to look at those patients and discovered that you guys were right. Access was the whole issue. They were seeing consults in the hospital, or they were seeing patients who had been admitted with urgent problems. At discharge, the physician would say, I need to see you back in the office in 48 hours. Call the office, make an appointment. Patient would call the office. Dr. Jones is booked for a month. We'll make an appointment for you in 31 days. Literally. And so, well, guess what happened? These patients bounced right back in again. They had no idea their access was that far restricted. None. And it was costing them in a big way, which they never put together. In a busy practice, you're seeing a patient in the hospital, you write a discharge. If they don't show up in 2 days, unless you've got a tickler system of some kind, you won't remember that, right? And they didn't. So they saw them again when they landed back in the hospital. Within 3 months, Kansas City was here. And then on the 4th month, they were acquired by a large university hospital. And I'm sure they're back up to here again. Interestingly, when they were acquired by that large university hospital, a new contract applied, and overnight I was paying $5 million more per year for exactly the same services from the same doctors in exactly the same clinics, except there was a new sign over the door. Okay? That's why we want to try and encourage these people to get better. Yeah.
Were they the only ones that went over to a hospital system?
Yes, they were the only group we lost. Yeah. All right, so let's go through to the ultimate outcome, and that's survival. Okay. Remember, we were looking at breast, colon, and lung cancer. I guess the good news is in breast and colon cancer, the results are good enough. It takes a long time to generate a survival curve. Unfortunately, in lung cancer, it doesn't. Those folks, even in the best of hands, don't do very well. But this is a comparison. Remember, we had a database of 60,000 patients who were in fee-for-service. That's the green line. The blue line is our episodes groups, and those survivals are statistically exactly the same, which is encouraging. Now, when we built this system, we wanted fail-safes. We didn't want people trying to reduce unnecessary care. And so the fail-safe was ultimately survival. If your patients did worse, you're out of the program. You can't stay in if you're not performing with good results. But it did raise the big question of, when we get done with all this, how the hell do we know how we did? So how are we going to measure whether this program was successful or not? So we did go back and we looked at the patients these groups had taken care of prior to episodes beginning. We pulled out about 500 of them. And we know what the cost of those patients was on average. So should we just say, all right, that was X. Now we're going to measure the episode pilot. That's Y. We'll put in an inflation adjuster. And if there's a difference there, they save money. Should we do that? Let's talk about that just a little bit. This is a different study that we did with a group in Denver, Colorado, year-over-year analysis. And when we looked at this, this is our Denver group. Prior to their intervention, they went on a pathways program and said they could control chemotherapy costs. So they were costing around $22,000 per patient in that period. This is per month. And our controls in the Southwest United States were up in the $31,000. And then in the following year, although their costs went up, not surprising, new drugs, everything inflates, but they were much closer to the operational controls in terms of, wait a minute, those are the control groups. Let's get this reversed. I'm sorry, I did this backwards. This is our group. They, in fact, stayed constant while the rest of the environment was increasing at a secular trend. Sorry about that. Okay? So, the difference from pre and post period, these guys were statistically significant and had saved money compared to the rest of the world. All right? It was not case mix adjusted. So when we case mix adjusted this, no difference whatsoever. It just happens from this period to this period, they had a few less expensive patients in terms of their cancers, and it made it appear that they had had improved performance. Okay? This is the model that Medicare is going to use for their new bundled payment. And I'm quite concerned that it won't be accurate because they're not case mix adjusting. Okay. So here's what we did. Remember I said we had a database of then 60,000 patients where we had clinical information, and we could put them in an episode and then measure their total cost of care. And then we did a retrospective case cohort control study. Everybody know what that is? There's epidemiology in the courses. So basically we're matching. If they had a premenopausal stage 2 ER positive HER2 negative cancer patient in the episodes group, we went out and compared that to the same patients in our reference database. And it took 810 patients before we could have enough volume to be statistically significant. And 3.5 years, unfortunately, to get those 810 patients. That's a long time. Okay? In our second phase, we found a different group. They will have their 810 patients in 5 months. So one lesson for us is big groups are really necessary to do this if we're going to make it, if we're really going to accelerate it and scale it. Okay. Now, the other problem here is that in cancer, the average cost of therapy is, let's say, $90,000. How big is the standard deviation, the variation on that 90,000? Anybody know? Take a guess. Give me a dollar figure. 90,000. So you think the standard deviation is as big as the mean? Anybody else have a number? 20? Pretty small, pretty tight, meaning people are doing fairly well. That means a lot of those TCs really were TCs. That's good. All right. Well, it's actually larger than the mean, just slightly. So if the mean's 90,000, the first standard deviation is about 100,000. And that's why we have to have such large numbers of patients in order to get a statistically valid analysis, because the variation is really, really big. And from a business viewpoint, a pragmatic viewpoint of getting this thing off the ground, that's problematic for us. Well, we got it done, and when we actually compared it to what we would have paid for those same 810 patients in a fee-for-service model over the same time period, so the patients were also matched for timeliness. That way we kept out any of the new drug confounders. This group came in at $33.4 million less on a $100 million spend. Now, if we see 3–4% reductions in a program, most of us are uncorking the champagne. That's a big deal in a large population-based program. So 34% for us was almost incredible. And in fact, we've got a fair number of people who still doubt that that actually happened. I'll show you how we got around that. But here's the other irony. Our chemotherapy costs skyrocketed compared to our control group. So we took away all the incentive to use more drugs, and it went up 178%. And we don't have a clue why. We have no idea. But even with that increase in drug spend, they were able to reduce total cost by $33 million on $100 million spent. Most of that reduction came from hospital care. The number of admissions in this group was dramatically lower. And in oncology, that is a huge quality issue, because the only reason you get admitted as a cancer patient is your toxicity from the treatment, or you're having a complication of the cancer. So if complication rates go down, you are doing better. You're having better outcomes. And most of that had to do with access. Okay? So I want to leave you with a couple of things. A, you're going to talk next session about, is it about cost or is it about quality? And I'm saying, hey, they're the same thing. I haven't been in a project where we've reduced costs where we haven't also improved quality. I can't name one yet. Now, I'm sure they're out there, but to start with the assumption that if you improve quality, the costs are always going to go up is bogus. And this is a beautiful example of that same thing. Second is, a big learning for me was collaboration gets us so much further. All my conversations most of the time with physicians are adversarial. You don't pay me enough. You denied something I wanted to give. That kind of stuff. But when we got to sit down on this and the data and we had the incentives aligned, everything was about how do we get patient care better. Man, could we go a lot further. It was a far more productive conversation. We're out of time, folks. You know, look at that graph I started with. We have to do things now. We can't be sitting around. And boy, do I not have all the answers. So as you start to look in oncology, our competitors are doing a lot of things that are different, and I think that's good, because none of us has the ultimate solution, and I'd like to see a lot more experiments occurring than we could. And then I thought I'd leave you with this. It was no accident, I think, that this was on our church bulletin Sunday morning as I was wrestling with, am I ever going to get this talk together? This was a prayer that I found just fascinating. This is what we are about. We plant the seeds that one day will grow. We cannot do everything, but there's a huge sense of liberation in realizing it enables us to do something and do it very well. I love those words. So I would urge each and every one of you in your institution to go out there and start trying something way different with the right intention, with careful thinking. There's never any excuse for not thinking things through carefully, but understanding you're going to fall flat on your face more than you will succeed. But at least we will be out there thinking about what's new and changing. And that, to me, is the real joy of innovation, because once in a while you get a hit, like we did. And that's so fun. But we are not finding the whole solution. We're going to lay some groundwork, we can make some changes, and that will make the next generation's work just a little bit easier. So with that, let me say thank you. It was a great conversation. I really enjoyed this group, and I understand why you're having fun. Thanks for the time.